Welcome back to the Elevated Dose with me, Carrie Ferrone. Today, we are doing something I've wanted to do since the beginning, a real, clinical, no fluff PCOS and GLP-1 deep dive. Not the TikTok version, not the just eat less version, not the PCOS is a weight problem version. The version where we talk about what PCOS actually is, why it's so often misunderstood, and what we know so far clinically about GLP-1 receptor agonists and dual incretins like tirzepatide in PCOS. And if you're listening because you have PCOS and you're exhausted, you're not behind, you're not lazy, you're not broken. You're navigating a condition that messes with hunger signals, insulin signals, ovarian signaling, and the nervous system all at the same time. So yeah, it's a lot. Before we start, this is educational only. It's not medical advice. Your body is not a group project with strangers on the internet. Please talk with your medical providers, especially if pregnancy is on the table for you. If you're like me and you live with PCOS, you know the experience isn't just symptoms. It's the way people talk to you about your symptoms. It's being told your labs are fine while your body is screaming. It's being told to lose weight like that's a plan instead of a punchline. It's being told your irregular cycles are just stress when you're staring at a pattern you didn't choose. And then because you're smart, you try everything. You track, you cut, you add supplements, you do the workouts, you become your own research department. And still, the body doesn't respond the way it should. That gap between your effort and your results is where shame sneaks in. And that's the part I want to burn down today, because PCOS is not a moral issue. It's a signaling issue. And GLP-1 medications, they sit right inside the signaling conversation. So if you felt like GLP-1s make sense for PCOS, you're not imagining that. There is a biological reason your intuition is doing cartwheels. So let's get into it. Polycystic ovarian syndrome has one of the most misleading names in modern medicine, and that mistake shaped nearly a century of misunderstanding. PCOS was identified and labeled in the early 20th century based on what physicians could see: enlarged ovaries with multiple small follicles visible on ultrasound or at surgery. The ovaries became the headline. The name stuck. And from that moment on, PCOS was framed as a gynecologic problem first, instead of what it actually is for most patients: a systemic, metabolic, and endocrine condition with reproductive consequences. That framing error mattered. When a condition is defined by what is visually obvious, everything else becomes secondary. Ovaries were examined, cycles were tracked, fertility was centered. Meanwhile, the metabolic terrain driving the condition was treated as background noise, or worse, a lifestyle failure. As diagnostic criteria evolved, the problem compounded. The NIH criteria emphasized hyperandrogenism and ovulatory dysfunction. Later, the Rotterdam criteria widened the net, allowing diagnosis based on any two of three features: ovulatory dysfunction, hyperandrogenism, or polycystic ovarian morphology. That expansion increased diagnostic access, but it also blurred mechanistic clarity. Patients with very different metabolic realities were now grouped under the same umbrella. From a research standpoint, this created heterogeneity. From a clinical standpoint, it created confusion. From a patient standpoint, it created disbelief. Two people can carry the same diagnosis and have completely different bodies, labs, symptoms, risks, and responses to treatment, and yet be given the same advice: lose weight, regulate cycles, manage stress. This is where PCOS quietly became moralized. As obesity rates rose globally, PCOS became entangled with weight stigma. Because many patients gained weight or struggled to lose it, the condition was increasingly framed as a downstream consequence of excess weight rather than a driver of metabolic dysfunction. The direction of causality flipped in the public imagination. Instead of asking why insulin signaling was abnormal, clinicians asked why patients weren't more disciplined. Instead of investigating why hunger cues were dysregulated, patients were told to eat less. Instead of recognizing hyperinsulinemia as a primary feature, insulin was treated as a secondary issue, something that might improve after you lose the weight. But in PCOS, insulin is often the opening move, not the aftermath. This is why so many patients heard the same sentence for years. Your labs are normal. Blood glucose often looks normal in PCOS for a long time. A1C can sit comfortably in range or in the pre-diabetes range. Fasting insulin may not be ordered at all, and yet insulin levels can be chronically elevated, quietly stimulating ovarian androgen production, altering fat storage patterns, disrupting appetite signaling, and driving inflammation. Normal numbers masked abnormal physiology. For patients like me, this created a specific kind of distress. The body is clearly not functioning normally. Cycles are irregular, hunger is unpredictable, weight gain feels disproportionate, energy is low, but the data used to validate concern fails to reflect lived reality. This is where self-doubt begins, not emotional self-doubt, but physiological doubt, the sense that one's body cannot be trusted, that effort does not translate to outcome, that rules apply differently to you. Over time, this erodes confidence in both medical systems and personal intuition. PCOS patients often become expert observers of their own bodies, not by choice but by necessity. They track, experiment, restrict, supplement, train, and adjust, often more meticulously than people without PCOS, and still see little, none, or inconsistent results. This is not because PCOS patients lack discipline. It is because the condition disrupts feedback loops that discipline relies on. One of the most damaging assumptions in PCOS care is that it presents the same way in everyone. It doesn't. PCOS is better understood as a spectrum of overlapping phenotypes driven by different dominant mechanisms. When PCOS is treated as a single condition, patients are compared against one another in ways that make no sense. Response timelines are judged, outcomes are moralized, treatment success is misattributed. Understanding phenotype does not require rigid categories, but it does require acknowledging patterns. The most common phenotype and the most studied is insulin-resistant PCOS. In this version, insulin levels are chronically elevated even when blood sugar appears normal. The pancreas produces more insulin to compensate for reduced cellular sensitivity. That excess insulin does not remain metabolically neutral. It acts directly on ovarian tissue, increasing androgen production. Androgens, in turn, worsen insulin sensitivity, creating a reinforcing loop. This is often the phenotype associated with central or abdominal weight gain, strong hunger signals and rapid return of hunger, difficulty losing weight despite consistency, irregular or absent cycles, acne or androgenic hair changes. For patients in this category, interventions that lower insulin levels or improve insulin signaling often have outsized impact. GLP-1 therapies make intuitive sense here because they address glucose-dependent insulin secretion, satiety signaling, and insulin dynamics upstream of willpower. Then, there is what is commonly called lean PCOS, though that's misleading. Lean PCOS does not mean metabolically healthy PCOS. It simply means that the patient does not meet BMI-based thresholds for overweight or obesity. Many people in this group still have insulin dysregulation, but it may present differently as reactive hypoglycemia, exaggerated hunger after meals, or subtle androgen excess without obvious weight gain. Because these patients don't look metabolically compromised, their symptoms are often dismissed more aggressively. They're told PCOS should not be affecting them this much. They're advised to eat more, stress less, or accept irregular cycles as benign. In reality, Their insulin signaling may still be unstable, just less visibly. GLP-1 response in this group can be variable. Some experience profound appetite normalization and improved cycle regularity. Others notice little change. The difference often lies in whether insulin dysregulation is truly central or whether other drivers dominate. Adrenal dominant PCOS is another pattern frequently overlooked. In this type, stress hormones play a larger role. Androgens may be elevated, but insulin resistance may be milder or intermittent. Symptoms often flare with psychological stress, sleep disruption, or overtraining. Weight changes might be less pronounced, but cycles can still be irregular. For this group of patients, GLP-1 therapies might help with appetite regulation and metabolic stability, but they are not a standalone solution. Nervous system regulation matters more here than caloric manipulation. Treating adrenal dominant PCOS as a weight problem often backfires. Post-hormonal contraceptive PCOS deserves its own mention. Some patients experience a rebound of symptoms after discontinuing birth control, irregular cycles, acne, hair changes that reveal underlying PCOS tendencies that were previously masked. Others experience transient dysregulation that resolves over time. In this group, timing matters. GLP-1 therapies may or may not be appropriate depending on whether insulin resistance is present or whether the body is simply recalibrating hormonally. Short-term symptom management is often conflated with long-term treatment need. There is also significant overlap between PCOS and autoimmune or inflammatory conditions. Thyroid disease, inflammatory bowel conditions, and systemic inflammatory states can coexist with PCOS and complicate insulin signaling. In these cases, GLP-1 response might be unpredictable, sometimes helpful, sometimes neutral, sometimes limited by other active disease processes. Finally, there is PCOS with cardiometabolic risk. This type often includes a family history of type 2 diabetes, early cardiovascular disease or dyslipidemia. Insulin resistance is usually prominent. Long-term risk, not just reproductive symptoms, become the central concern. For these patients, like me, GLP-1 therapies may serve not only as symptom support, but as risk-modifying treatment. The conversation shifts from aesthetics or cycles to long-term protection. This is where GLP-1s stop being framed as weight loss tools and start being understood as endocrine interventions. And this is where comparison becomes dangerous. When patients compare their GLP-1 experience to someone else's without understanding phenotype, they assume something is wrong with them. They conclude the medication failed, or that they didn't do enough, or that they waited too long. In reality, bodies respond based on the dominant signal driving dysfunction. Until that signal is identified, treatment feels like guesswork. For many PCOS patients, including myself, GLP-1s work not because they suppress appetite, but because they stabilize feedback loops that were never functioning normally to begin with. And to understand why that matters so deeply, insulin has to be examined more closely, not as a number, but as a signaling hormone with far-reaching effects. For us to understand why GLP-1 therapies make sense for PCOS, we have to talk about insulin, not as a value on your labs, but as a signaling hormone with influence far beyond blood sugar. Insulin's job is often described too simply. It is framed as the hormone that lowers blood sugar, and once glucose looks normal, the conversation stops. But insulin is not just a glucose regulator. It is a growth signal, a storage signal, and a communication signal between organs. In PCOS, that communication system is frequently distorted. Many of us with PCOS do not start with high blood sugar. We start with high insulin output. The pancreas produces more insulin to keep glucose normal, and for a long time, it succeeds. Blood sugar stays in range. A1C looks reassuring. Nothing appears wrong on paper. But the body is operating in a high insulin environment. That matters because insulin does not act in isolation. It interacts directly with ovarian tissue. It amplifies androgen production. It changes how fat is stored, favoring central and visceral accumulation. It alters how the brain perceives hunger and fullness, and it influences inflammation pathways throughout the entire body. This is why PCOS is often described by patients as feeling out of sync. Hunger arrives suddenly and intensely. Meals that should satisfy don't last. Energy fluctuates in ways that feel unrelated to our behavior. Weight gain occurs without proportional intake, and attempts to correct the problem through restriction often make our symptoms much worse. This is not because patients are eating incorrectly. It is not because patients aren't exercising. It is because insulin is sending our bodies mixed signals. One of the most misleading aspects of PCOS care is the reliance on fasting glucose and A1C to assess metabolic health. These markers tell a narrow story. They describe blood sugar at a moment in time or averaged over weeks, but they do not capture how much the pancreas is working to maintain that normality. In PCOS, the pancreas often works overtime. Insulin levels can be elevated for years before glucose rises. During that time, insulin continues to exert its effects on the ovaries, adipose tissue, and brain. And because insulin resistance is not uniform across tissues, some organs respond strongly while others do not. The ovaries are in particular sensitive to insulin. When your insulin levels are chronically elevated, ovarian tissue interprets that signal as a growth cue. Androgen production increases. Those androgens then interfere with follicular development, contributing to irregular ovulation and cycle disruption. At the same time, androgens worsen insulin sensitivity in muscle and fat tissue, just reinforcing the cycle. This is why PCOS often progresses quietly. The condition does not announce itself with dramatic lab abnormalities early on. It accumulates momentum through subtle signal distortion. Hunger is one of the earliest cues. In PCOS, hunger is often described as urgent rather than emotional. It does not feel like a craving or a habit. It feels like a physiological demand that escalates and is difficult to ignore. This is because insulin fluctuations influence how the brain interprets energy availability. When insulin spikes and falls rapidly, glucose delivery to the brain can feel inconsistent, even if blood sugar remains normal. The brain responds by driving food-seeking behavior. This is not a lack of control. It is a protective response to perceived instability. Traditional diet advice, eat less, move more, ignores this reality. Telling someone with PCOS to eat less without addressing insulin signaling is like lowering the thermostat without fixing the broken wiring. The body compensates, hunger increases, stress hormones rise, metabolic efficiency decreases, and the PCOS patients like us, we internalize the failure. This is where GLP-1 therapies enter the picture, not as appetite suppressants, but as signal stabilizers. GLP-1 is a hormone released in response to eating. It enhances insulin secretion in a glucose-dependent manner, meaning it supports insulin release when glucose is present and tapers off when it's not. It also suppresses glucagon, slows gastric emptying, and communicates satiety to the brain. In a system where insulin output is chaotic and hunger signaling is loud, GLP-1 acts like a mute button. Food stays in the stomach long enough for fullness signals to register. Insulin release becomes more proportional to intake. Glucagon is restrained. The brain receives clearer information about energy availability. For many PCOS patients, and this was me, this was the first time hunger felt predictable. Not absent, but predictable. And that distinction matters. When hunger becomes predictable, behavior becomes possible. Meals can be spaced, protein intake can stabilize, strength training can be fueled appropriately. Restriction is no longer required to maintain control. This is why GLP-1 therapies often feel profoundly different from dieting. They don't rely on overriding hunger. They reduce our need to fight with it. But insulin is only part of the story. To understand how this plays out clinically, the trial data has to be examined, not through headlines, but through context. If you're listening because you're trying to understand access, medical support, or what a safe clinician-led process can look like, this episode is supported by my telehealth provider, Fridays. Fridays connects patients like you and I to licensed clinicians for evidence-based metabolic care and ongoing support. If you're exploring options, you can learn more through my link in the show notes. Important. I'm an affiliate, and you should always review risks, benefits, and your medical history with a clinician. This show is education, not personalized medical advice. The clinical evidence for GLP-1 therapy in PCOS did not come from weight loss clinics or social media trends. It came from endocrinology and reproductive medicine, often in populations that had already failed standard treatments. The strongest body of evidence come from studies using liraglutide and exenatide, both older GLP-1 receptor agonists. These medications were studied before the current cultural focus on GLP-1s, which makes the data particularly useful. The trials were not designed to prove popularity. They were designed to answer specific questions. One of the most frequently cited, randomized, placebo-controlled trials examined liraglutide at a dose of 1.8 milligrams daily in women with PCOS and obesity. Over the course of treatment, the patients receiving liraglutide experienced reductions in body weight and waist circumference, which was expected. What mattered more were the hormonal changes. Sex hormone binding globulin increased, free testosterone decreased, ovarian volume was reduced compared with placebo. These are not cosmetic. These are markers of a shifting hormonal environment. Importantly, gastrointestinal side effects were common, particularly nausea. This was not a trivial finding. It reminds us that GLP-1 therapies are powerful endocrine tools, not benign supplements. Tolerability varies, and treatment decisions must weigh benefit against burden. Subsequent studies explored liraglutide both alone and in combination with metformin in women with PCOS who had poor response to metformin alone. These trials consistently demonstrated greater weight loss with liraglutide-based therapy, along with improvements in metabolic parameters. What is often overlooked is the patient population. These were individuals who had already tried first-line therapy and remained symptomatic. The benefit was not theoretical, it was observed in patients who exhausted standard options. Exenatide, which was the first GLP-1 to hit the marker, also has notable research footprints in PCOS. In randomized trials comparing exenatide, metformin, and combination therapy, outcomes included menstrual frequency and ovulation rates in overweight, insulin-resistant women with PCOS. Exenatide alone or combined with metformin was associated with improvements in reproductive outcomes alongside metabolic changes. Meta-analyses comparing exenatide to metformin have suggested higher pregnancy and ovulation rates in exenatide-treated groups. However, these findings must be interpreted carefully. Study sizes were small, protocols varied, weight loss likely contributed to reproductive changes. This is where nuance matters. Improved ovulation does not mean GLP-1s are fertility drugs. It means that stabilizing insulin and metabolic signals can create conditions where ovulation becomes more likely in some PCOS patients. Semaglutide presents a different situation. Semaglutide is newer, more potent, and widely used. But PCOS specific randomized control trials are still emerging. Much of the current understanding is extrapolated from obesity and diabetes research, combined with smaller controlled studies and observational data. This gap creates confusion because semaglutide is effective for weight loss. It is often assumed to be superior for PCOS. Mechanically, it may be, but evidence must catch up to intuition. This is why ongoing trials focus specifically on menstrual regularity, metabolic markers, and fertility outcomes in PCOS are so important. Tirzepatide adds another layer of complexity. By acting on both GLP-1 and GIP receptors, tirzepatide may influence insulin sensitivity and adipose signaling differently than GLP-1 only therapies. This has led to interest in its potential role in PCOS, particularly in patients with significant metabolic dysfunction. Ongoing placebo-controlled trials are now examining tirzepatide's effects on ovarian function in PCOS patients. These studies represent a shift in research priorities from weight as the primary endpoint to reproductive and metabolic outcomes as central questions. Still, there are limitations. PCOS trials are often underpowered and underfunded. They enroll heterogeneous populations, they struggle to isolate insulin effects from weight loss effects, and fertility outcomes are notoriously difficult to measure in short term studies. This doesn't mean the data is weak, it means it must be read with care. Absence of definitive evidence is not evidence of ineffectiveness, it is a reflection of how slowly medicine studies conditions that predominantly affect women. What the existing data supports is not a promise, but a rationale. GLP-1 therapies can improve metabolic stability in many people with PCOS. They can reduce insulin exposure, normalize appetite signaling, and shift hormonal environments in favorable directions. For some, this leads to cycle regularity. For others, it leads to improved energy, reduced inflammation, and metabolic protection. The variability is not a failure of the medication. It is a reflection of the underlying heterogeneity of PCOS itself. And this is where the conversation must move next, from initiation to continuation, from short-term response to long-term care. Because for many PCOS patients, the hardest part is not starting treatment, it's deciding what happens after the body finally feels stable. For many women with PCOS, the most destabilizing moment is not the start of treatment. It's the moment when things finally feel steady and the question shifts from how do I fix this to what am I supposed to do now? This is where PCOS diverges sharply from the standard weight loss narrative. In a typical weight-centric framework, treatment is framed as temporary. There is an implicit finish line. The body reaches a target weight. Habits are assumed to be learned, and medication or intensive support is expected to taper away. Maintenance is framed as discipline, the reward for having done things right. I don't agree with this, and PCOS does not work like this. PCOS is a condition of disrupted signaling. When treatment improves that signaling, it is not because the condition has resolved. It is because the environment has changed. GLP-1 therapies do not erase PCOS. They change the context in which it operates. This distinction matters when maintenance is discussed. In PCOS, appetite regulation is not merely a behavioral issue. It is closely tied to insulin dynamics, gut-brain signaling, and ovarian hormone feedback. When those systems are stabilized pharmacologically, the body operates in a different mode. Removing that support does not return the body to a neutral baseline. It returns it to its prior state, often abruptly. This is why many people with PCOS report that coming off a GLP-1 feels disproportionately difficult. Hunger does not simply come back. It hits like a freight train, quickly, often with an urgency that feels out of proportion to intake. Energy fluctuates, cravings intensify, cycles may destabilize, weight regain can occur rapidly, even without changes in behavior. This experience is frequently misinterpreted as dependency or failure. In reality, it reflects the reemergence of the underlying signal disruption. Insulin output increases, appetite signaling becomes erratic. The brain, which had adapted to quieter metabolic environments, is suddenly asked to manage noise again. Stress hormones rise in response to perceived instability. And the patient is left trying to distinguish between physiological signals and moral judgment. Back to the beginning, where the shame hits like a truck. The assumption that maintenance should require less support is rooted in the idea that the problem was behavioral to begin with. But when the problem is endocrine, reducing support can increase instability rather than promote independence. For PCOS patients, long-term or maintenance dose GLP-1 therapy is not about continuing weight loss. It is about preserving metabolic predictability. Predictability is what allows life to expand. When hunger is predictable, meals can be planned without obsession. When energy is stable, movement can be chosen rather than forced. When cycles are regular, reproductive health decisions become clearer. When insulin exposure is reduced, long-term cardiometabolic risk may shift. This reframes maintenance entirely. Maintenance is not about holding a number on the scale. It is about maintaining signal integrity. Dose reduction in PCOS must then be approached carefully. Reducing dose may be appropriate for some, particularly if insulin resistance has improved substantially or if other stabilizing systems are in place. But abruptly discontinuing medication exposes how much unseen work the medication is doing. This does not mean that GLP-1 therapy must be lifelong for everyone. It does mean that the decision to continue or discontinue should be based on physiology, not stigma. The same way insulin is not withdrawn from someone with diabetes simply because their glucose improved, metabolic support should not be withdrawn from someone with PCOS solely because weight changed. The body does not remember intent, it responds to signals. For patients navigating maintenance, this can be emotionally complex. There is often relief, finally feeling normal. I know there was for me. And there is often fear, the fear of losing that stability. The cultural messaging around GLP-1s amplifies this fear by framing continuation as weakness and discontinuation as virtue. Neither framing is clinically sound. PCOS requires a longer view, and that longer view is where medicine still has gaps. Despite the growing interest in GLP-1 for PCOS, significant questions remain unanswered. Acknowledging these gaps is not a weakness. It is what separates evidence-based care from ideology. One unanswered question is whether early metabolic intervention can alter the long-term trajectory of PCOS. If insulin dysregulation drives androgen excess and ovulatory dysfunctioning, then addressing insulin earlier could theoretically reduce cumulative exposure to metabolic stress. But the data is limited. Most trials are short. Few follow patients across decades. We do not yet know whether early GLP-1 use changes lifetime cardiometabolic risk or reproductive outcomes in a measurable way. Another unanswered question is how PCOS interacts with life stages. PCOS does not disappear with age. Hormonal patterns shift during perimenopause. Insulin sensitivity often worsens, and cardiovascular risk increases. How GLP-1 therapies interact with these transitions is still being studied. Most PCOS research focuses on reproductive age women, leaving a gap in understanding later life management. There is also limited data on phenotype-specific response. While clinical experience suggests that insulin-dominant PCOS responds more robustly to GLP-1 therapy than adrenal-dominant patterns, formal trials rarely stratify participants this way. Without phenotype-specific analysis, variability is misread as inconsistency rather than expected heterogeneity. Fertility remains a particularly sensitive area. Improved ovulation has been observed in some patients receiving GLP-1, likely secondary to metabolic stabilization and weight change. But GLP-1s are not fertility medications, and they are not recommended during pregnancy. Washout periods are required. The transition off therapy must be managed carefully to avoid rebound instability. The cultural narrative around surprise pregnancies oversimplifies a complex physiological process and places responsibility back on patients to anticipate outcomes medicine has not fully mapped. Finally, there is the question of access. GLP-1 therapies remain expensive. Insurance coverage is inconsistent. PCOS is still under-recognized as a metabolic condition deserving of treatment parity. This creates a two-tier system where those with access receive support and those without are told to try harder. This is not a failure of individual clinicians. It is a systemic lag. PCOS has lived in the shadows of endocrinology for decades. Too reproductive to be fully metabolic, too metabolic to be fully reproductive. GLP-1 research is forcing a reckoning. What is becoming clear is this: PCOS is not a willpower problem. It is not a discipline problem. It is not a temporary phase to outgrow. It is a condition of disrupted signaling. GLP-1 therapies do not solve PCOS. They do something quieter and more powerful. They give the body a chance to operate under clear instructions. For many patients, like me, and maybe like you, that clarity is the first thing that has ever worked. And if that clarity allows effort to finally translate into outcome, if it restores trust between a person and their body, then the question is no longer whether the tool is justified. The question becomes whether withholding it ever was. Now, I want to talk about what's in progress because this is the frontier. As of the time of recording, clinicaltrials.gov includes PCOS-specific trials evaluating tirzepatide for ovarian dysfunction in premenopausal women with PCOS who have overweight or obesity in a double-blind placebo-controlled design. Semaglutide trials focused on menstrual regularity and metabolic outcomes in people with PCOS who are already on metformin but still have irregular cycles. Semaglutide trials looking at metabolic abnormalities and fertility outcomes in obese, infertile women with PCOS, and an adolescent PCOS study comparing weight loss via oral semaglutide versus intensive dietary intervention designed to examine metabolic and reproductive measures. These trials matter because they move the conversation from weight loss as a side effect to PCOS outcomes as the primary endpoints. So this is your permission slip. If PCOS made weight loss feel impossible, that wasn't you failing. That was physiology. And if a GLP-1 helps your body finally respond to the effort you've been putting in for years, that's not cheating. That's treatment. If this episode hit, share it, leave a comment, and make sure to follow the show. See you next time.